I know the agenda says Mufti Zubair. Unfortunately, his father was taken ill, he's not too well. We'll pray Allah subhanahu wa ta'ala gives him a speedy and complete recovery and makes it easy for him. So, Maulana Yunus.
Bismillahirrahmanirrahim. So, the National Burial Council has been running now. This is our 7th annual conference, and I think just before we begin, the reason why we have these conferences is to understand our duties, our responsibilities, to understand the law around death, dying, burials, funerals, cemeteries, all of these areas that we are involved in, and try and share that learning and try and understand what we are allowed to do, what we are not allowed to do, what is best practice. Unfortunately, we have 3 very senior speakers who understand the law around death, burials, funerals, Dr. Alan Fletcher, Austin Hayes, Derek Winter. So all of these areas, hopefully, we will learn quite a lot in terms of where we are today and where the law is heading in the future. I think one of the things that I just wanted to mention is make dua for Mufti Zubair's father. May Allah subhanahu wa ta'ala grant him and the family ease. I wanted to thank the MBC committee for all their efforts in preparation for this conference. Muhammad Umar as the chair, and then all of the others, especially those who are in Birmingham, Muhammad Mangera, Sister Sabiya, Ismail Bhai, and Men Gulam Bhai, and all the others, Rizi, all of the other committee members who have been tirelessly working in the background to make sure that this goes well. A few reflections. In the past week, we're here to discuss about funerals and death and dying, and obviously one of the biggest deaths that happened in this country recently was the death of Her Majesty the Queen. And we saw a lot of rituals, we saw a lot of religion, we saw a lot of liturgy, we saw pomp and ceremony, and we saw planning and preparation like clockwork, professionalism. And I think for us as Muslims, there's a lot to learn from that funeral in terms of precision, in terms of professionalism. And yes, our funerals are different. There is no pomp and ceremony. Even when a leader dies, there is no pomp and ceremony. Recently, one of the founders of, or the princes and the kings of Dubai, he died earlier in the year. And he died on the Thursday and he was buried on the Friday. And his grave is extremely simple. And the ceremony is extremely simple. And I think that's the difference that we have within us. Our funerals will not change in terms of how simple they will remain. But in terms of professionalism, in terms of our standards, in terms of our understanding of the law of this country and to do it according to the law and improve our standards, that's what we're here to try and learn and share as much as possible. So that's the purpose of having this conference. There are many people here from many parts, different parts of the country, whether Scotland is represented. Where's Rizzi? Yeah, okay. So Rizzi is representing Scotland. We've got Wales represented. We've got Yorkshire, Lancashire, London. Usually brothers from Southampton are here. So all over the country we've got brothers. And some practices are much better than others. Some councils are much better than others. And what we need to understand is which council is the best and how can we replicate that in our place. which practice is the best, and how can we replicate that in our place. And that's what we're here to share and learn. So thank you again for attending, taking your time out on a Saturday. May Allah subhanahu wa ta'ala make this extremely beneficial for each and every one of us. And now I would welcome Dr. Alan Fletcher, the National Medical Examiner, who will talk about the rollout of the medical examiner system in the community. And then we will have question and answers for Alan will be immediately after his speech because he needs to leave by 11 o'clock. So therefore, his question and answers will be immediately after his talk. Thank you.
Thank you, and good morning, and assalamu alaikum. Thank you for the invitation to an opportunity to come talk to you today. I personally find fully respect the authority and importance of the National Burial Council as the voice with which proper communication can continue. And I'm just at the outset like to extend my support for the council, and especially my main interactions through the chair, through Mohammed Omar. It's my intention to give you an update on the progress of implementation and of the medical examiner system. At the start, I want to just remind you all and myself that our primary focus for this has always been about bereaved people. This has been the case before implementation, when the system was the genesis of it, during it, and I wish to preserve it for the future. That is our focus. It has been 3.5 years since we started implementation of the non-statutory system. 2/3 of that were in the full pandemic, and despite that, we have made some really excellent progress. Just pausing to reflect though, I know how hard the pandemic hit sections of your community, especially. And I would just like to acknowledge that I admire the strength of your community, the dignity and the compassion with which you managed this exceptionally difficult time. Since I last spoke to this conference, a lot has happened. And I'm going to just touch on main topics as I give you this update. First and foremost is the legislation, for which I'm not personally responsible for, but I can update you. The Health and Care Act was gained royal assent earlier this year, and that set in place the opportunity for the statutory system for the medical examiner system, amongst other death certification reforms. There has been a written ministerial statement, and the ministerial statement said that it is this government's intention to implement the statutory system for the medical examiner system from April 2023. And I would just ask you to pause and consider those very carefully chosen words. From does not mean on. It means that the intention is to do this as soon as we can, and emphasis on can, from at some point after April 2023. Now, what does that mean in practice? For me personally, it means that we have to be ready, and I'll come back to that. But it also means the passage of secondary legislation, which carries the detail, if you like, for the changes to medical certification of the cause of death, the medical examiner system, the national medical examiner's role, and more. That is in progress. I can't tell you more about it. It isn't for me to decide. It is for the lawmakers to decide the detail. But as far as I possibly can, I want to ensure that the medical examiner system in the non-statutory system reflects what will come in the statutory system, and that will be the law. It's also important this legislation reflects the modern healthcare system and also is future-proofed. Reforms for the death certification process have not happened for many years. The current Act is dated 1953. A lot is different in that 70 years. To mention progress of the implementation, we have scrutinised now over 300,000 deaths in England and Wales. And I know from the feedback I have had, formal and informal, that there are benefits to bereaved people. Those are realised. But there are also benefits to patient safety, to coroners, their officers, and registration services. In particular, for example, medical examiner input has reduced, in general, those rejections of certificates that cause untold distress when they are delayed and need coroner notification at the point of registrar receipt to virtually zero. Pause and think what that means. As we have gone along, it has always been my view that important relationships need to be built with stakeholders. And that includes at a national level, through my regional medical examiner teams, and at a local level. And I'm very grateful for those connections that have been made, including to the Muslim community. I've a specific brief to talk about rollout to the non-acute sector. And I will be clear with you that this has not gone as fast as I would have hoped. And the reasons are simple. We are living in difficult times, not least the pandemic, but there's an awful lot of change, uncertainty and anxiety in all walks of life. And I recognise that this must not be a doctor-focused programme. It must be a population, public-facing, respecting the requirements of the people that it is intended to serve. The non-statutory system also presents its challenges, because if somebody doesn't have to do something, they don't want to do they? That is the challenge I face. There is a balance to be struck, because it is also an opportunity to test, refine, learn, improve, before something changes to a full statutory system. I want to make the most of this opportunity at a national and local level. The non-acute sector is complex. It isn't just about general practice. It's a big part of it. It also includes community hospitals, community mental health trusts, and independent providers. I know that there has been a challenge in some places, not all by any means, to engage with general practice and general practitioners. I'm doing my best at a national level, and my colleagues at a regional level are doing their best to promote, to say, general practice, please, come on board. And I respectfully ask you as community leaders to encourage your GPs to engage and to make connections, to test. Let's work it through. Let's get the systems working so that when we get to the statutory system, everyone gets the best of the system. We have permissions in place from the Secretary of State via an order to enable the medical examiner offices to scrutinise cases outside of their walls. We also have permission for healthcare providers of any kind to share records with medical examiner offices. The practicality of that has been challenging, frankly. I've been asked to produce a national IT solution for the whole of the NHS. No pressure there then. And you know what, we've done our best. We've done it pretty well, but local solutions are the best way forward at the moment. And to assist with the rollout, we have had a good practice series of guides from my office. These focus on areas of good practice. I'll mention another one in a moment. But for example, the recent guidance earlier this year on post-mortem examinations for medical examiners, information they need to know, was I'm very grateful for the support of Mohammed burial accounts for their input into that from a faith perspective. So, the next part of this talk is a little personal, because it is my nature, personally and professionally, to try to do my best to meet the varied expectations others have of me. Your community is no exception. And therefore, I would like to take a few minutes to talk about your concerns. I know what these are. I know what they are because Mohammed tells me what they are. He sets them out of all of the medical examiner and medical examiner officer training days. He has been incredibly supportive, and I'm very grateful for having attended each and every one like I have. I have been over 40 now. He is such a consistently sensible and helpful advocate for your community. I'm very grateful. In medical education, there is great value in repeating learning and revising. I know Mohammed's slides so well now, I'm going to take his concerns individually and describe to you how I have listened and what I and we have done. There are 12. Number 1, and he always said it is the number 1, is out of hours. I get it. I know the concern that you have, I don't need to repeat it. What we have done is to create some out-of-hours guidance. It was published this month with assistance from the Royal College of Pathologists. That guidance was helped enormously by input from Mohammed Omar and Mohammed Mangera this month. That has set in place the opportunity for all medical examiner offices to know what the rules are to like that. I mentioned that the non-statutory system presents a challenge, but it is also an opportunity to test and refine, and it's already underway at several offices. So we are learning, we're in listening mode, and doing our best to get this right. Funding is available for this. I have a budget set for this programme that includes provision for out-of-hours service provision. It has to be proportionate, it has to meet the needs of the population, it has to be aligned to other out-of-hours services, notably coroners and registration services. So it may not be absolutely perfect, everything that everybody wants, but the Mini, as opposed to the Mercedes, is good enough. It's not just about faith reasons. There are several reasons for out-of-hours arrangements, and I want to make sure that this is even-handed and considers all the applications. It is incredibly important that each office has strong local contacts with the community that it serves. I know that works well in many places, and I have reiterated lots of times that it is so helpful to have a single, one or two knowledgeable contacts and knowledgeable calls as opposed to 20. And so my only request as I go through this talk to you as the community is to ensure that to provide that collaboration to ready, listening, willing local offices to build those connections so that that can work well. Number 2, delays. You can see where I'm going with this, and I know Mohammed's concern. Again, I don't need to iterate the causes, the concerns. I am aware of anecdotal delays that have been attributable to the medical examining service. I know that. I am wary of reacting to individual cases from a national perspective, but I maintain my principle that just one avoidable delay that causes distress is regrettable and to be learned from to avoid again. It isn't fair to place all the responsibility of delay for the process at the door of a medical examiner system. It is sometimes, but there are other players in this, including a attending practitioners' availability, coroners, their officers, their decisions, their need to investigate or not, and registration services and their availability. We need to work together to make sure that we have a system that works seamlessly, as was described just now regarding the £50 million that it cost for the Queen's funeral. That's my budget, by the way, for the year. Right, the £500,000. We have an emphasis during the training on the importance of the faith community. It is singularly, it is such a prominent part of the medical examiner and medical examiner officer face-to-face training, deliberately to ensure that this is fully strongly aligned. Please also be aware that some processes and offices are maturing, some of them are young in all of this. They are improving all the time, so your patience is welcomed. Number 3, we get quicker. Mohammed has a concern that there will be sufficient numbers of MEs, medical examiners. We have trained over 1,600 medical examiners now. They reflect 80% of the workforce in place at the moment. It's not 100% note. So that 20%, that headroom, will, I expect, to be enough to get us to the line where we scrutinise all the deaths. Training of staff is number 4. We have trained 470 people as medical examiner officers. They are an integral part of the workforce. They have been relatively later in the process, but they are a key link person, a constant in an office that enables that communication to meet your requirements. I mentioned the emphasis in training days of the faith community, but we also have extended this through education beyond the medical examiner office staff. We know that it's important through links with other government departments, and coroners officers. We have joint training with coroners, and coroners officers now are supported by medical examiner offices. Those links are essential to try and ensure that communication is first and foremost, followed by communication, and third, communication. Now, that communication also extends to medical and nursing colleagues and allied healthcare professionals. And getting the communication plan right for everyone, both within the health service and outside, the public, stakeholders, is critical. Timing is critical. If we raise expectations or put fear into the minds of those who are going to be the recipients of this service, or those who are responsible for delivering it but are not yet ready, we will do a disservice to this. Timing is everything. Please be aware, I've got it very much in my mind that we get this right. We have a plan, and you will be notified. That is a shared responsibility. It's not just about me acting in isolation. It's Department of Health and Social Care, other stakeholders, and I want to link with the Council, the National Burial Council, to ensure that you are achieve the right message at the right time. Don't hear it second hand. Number 5, cost implications to the family. You said you didn't want to pay for a service. I agreed, and look, it's gone. I consider that a bit of a win. Yep. Number 6, independence of the medical examiner. I understand this point. We have medical examiners and officers employed in trusts for pragmatic reasons. I have raised the point that this needs to be clear in the statutory system from an accountability and an independence perspective. I mentioned we've scrutinised over 300,000 deaths. It has not been raised as an issue in those 300,000 cases to me. There is, of course, with the Health and Care Act, a shift in orientation from the NHS, from acute hospital trust providers to integrated care systems and integrated care boards. And I welcome that because I think that strengthens the independence and sort of lines of reporting and accountability. I'll acknowledge it is possible that beneath the surface there is an issue with doctors and officers acting in a non-independent way. But I find that hard to believe, knowing why medical examiners and medical examiner officers have entered their roles. Number 7, the role of the National Medical Examiner. Well, I stand here before you as the National Medical Examiner, and it feels decidedly uncomfortable to tell you what I think I should be, what my role should look like in a statutory system, because that's for somebody else to do. It needs to be future-proofed, but when whoever is doing this role for this service. Number 8 is the non-statutory system and the problems it creates from a don't have to do it perspective. I've mentioned that this is an opportunity to test and refine. Technically, yes, if somebody doesn't want to do it until the statutory system actually flicks the switch and there's the date, that is their prerogative. It's not what the National Medical Director for the NHS has told them in a letter, but we'll keep working on that. Ultimately, there comes a point at which one needs to point out that the profession who don't engage with this, the medical profession, are risk breaking the law when it comes statutory. Why wouldn't they get involved? Number 9, inconsistencies. Mohammed refers to a postcode lottery. It's true, there are differences, and there are inconsistencies. We have got the challenge of, well, I have the challenge of herding a group of cats of medical examiner officers in a non-statutory system. But there are differences, aren't there, in demographics, of population, hospitals and geography. So there are going to be differences between offices. My principle is that the core components of scrutiny in the medical examiner system that we set out in training and in guidance, especially the Good Practice series, are constant, and that they will be strengthened by legislation. I put reminders in bulletins and some information for you about quality assurance, because this, we were focused on starting. Now I'm in a place of assuring quality of service. And I've rocked the boat in NHS England, not focusing on numbers, targets. Instead, my quality assurance proportionate and pragmatic has the experience of bereaved people as its focus. That is my quality assurance measure. It's going to be, it's in development and it will be released soon, a month or two. Number 10, I like this one, because Mohammed says, advantages, better documentation. And it's not a concern, that's why I like it. It's the 1 out of the 12 that isn't actually a concern. And I agree with him. It is, we have got better documentation and it is an improvement. Number 11, will it reduce referrals to the coroner? And my answer to that is cautious, because yes, we have evidence that it is reducing referrals to a coroner. And the answer is sometimes. It's complex because during the pandemic, we've had some changes to the way that death certification occurred. Some easements that I know were extremely helpful to the community. And we've reverted back for some of those to the way things were. I'm mindful to do what we can to improve matters for the future. So the secondary legislation, we have this interim period until the statutory system starts, and I'm optimistic that you will see this simplified and improved. So please watch that space and read between the lines of what I've just told you. We are getting correct cases notified to coroners. Some of them are complex. We are certainly avoiding unnecessary referrals and reducing registration office rejections. Some of those referrals are happening because of challenges of availability of attending practitioners in the criteria that we currently exist. That is what I was seeking to simplify. Number 12, the last one, we're breathing a sigh of relief. Discussions with the family about the cause of death. Mohammed quite rightly points out that this is not the most important thing for family members at the time of death. I get that. And many examiners get that. We have to take the decisions on the best information we have at the time. And that's fine too. There is always an opportunity to reflect and raise concerns later. We can facilitate the process. But if a family or community member wishes to raise a concern after everything, we're not going to be cross. We'll listen. And we'll do what we can to help. So it's not a complaint answering service, I just want to be clear about that. It's just, if there is something on reflection that people wish to raise, they are welcome to do so at any time. So in summary, I have listened to you and your community's concerns, and I've done my best to address them with the resources that I have at my disposal. I will continue to listen, and my regional and med examiners and officers and I value the opportunity to have continued dialogue with you and your representatives, inshallah. We have come a long way down this road. It's really important. I consider the goal is in sight and that we are nearly there. We do not want to fail at this last stage. We owe it to the families affected by Shipman, Gosport and too many others to list. Thank you and shukriya.
Well, thank you very much for a really in-depth insight and also sharing of all the where you're going and also some of the key issues. Once again, I'd just like to also say that thank you so much for the opportunity for us to input into some of those policies that have been developed so that we can have a say on behalf of the community. Alan's got to leave early, so I think rather than me talk about that, maybe have a few minutes to have some questions and answers. But it's probably one of those sessions where he's actually answered most of the questions and most of the issues that most of us would want to raise. Very cleverly done, but there we go. It might be an opportunity to have something different to ask him while he's here before he leaves. So if you put your hand up, tell us where you're from, who you are, and a quick question. You only have 5 minutes or so. Thank you so much.
1, 2, 3.
Hello, good morning, Mr. Allen. I'm Parvez Qureshi. I'm a funeral director from London. You have very elegantly said the changes is coming in terms of statutory system. But our biggest concern, Maulana said at the beginning, is the prioritizing. Because we don't want the statutory system to be overcrossed or anything. But prioritizing issuing MCCD is one of the biggest concerns we have. And it varies from places to places. Some cases we see that as soon someone especially died at home, family goes to the GP or goes to the GP. They don't necessarily prioritize for Muslim families, knowingly that Muslim and Jewish community has got the urge to, bury their deceased as soon as possible. So can you highlight on this regard? And second question is, in terms of non-invasive postmortem, I don't know whether you are the right person to answer this question, and then I'll come back later. Thank you.
Thank you very much. I understand your point entirely. My feedback from reporting, because I have reporting of numbers, is that where the medical examiner officers have been asked notified of urgent requests for release, for whatever reason, they have been able to fulfil those requests in 90% of cases. I want it to be 100, but 90 is good. That would be an A star at GCSE, seeing as where we are. Your point about prioritisation is very well made. I understand that entirely. It is fully appreciated by medical examiners and officers because they're educated that way. You're very partly to the priority for attending practitioners because medical examiners can only do what they do if somebody writes a certificate. I can only influence that in part. May I suggest that one way that can happen is through the respected and trusted contact that the community may have locally. If that person gets in touch with a medical examiner office, they can preemptively say, "Hello, medical examiner office here, general practice. We've heard that there's a death. It's urgent. Can you help us get the paperwork and everything sorted?" In fact, it can work to your advantage because there's another person, not necessarily via a receptionist, who is making that request. So we can speed things up that way in some cases. If we know, if you tell us about the death.
Can the prioritization not become statutory? In a lot of cases, can we not request to be statutory to prioritize Muslim and Jewish community death?
I'm not in that position to be able to do that. That's for the lawmakers.
Assalamu alaikum. My name is Javed from Sadqa Jari organisation. Now, practice and theory are two different things. So where trusts are already testing this, you're saying you're not getting the feedback, but we're definitely getting the feedback in terms, our organisation can pick up a body within an hour in certain hospitals from start to finish, 24/7. Medical examiners are obviously not working those hours. They're already where they're being tested, are delaying that process. And it's very difficult to let families know that actually this is the reason why they're being delayed. And that's why they're being negative. And also what it's doing is adding pressure, the fact that we can't do burials first thing in the morning because we're waiting for medical examiners. And the medical examiners, when we try to contact them, are unapproachable. And we can't get a timeline. So ideally, if they are being introduced, then we really need to know what are the timelines, in terms of them looking at. We don't even get that feedback. So we can't plan for that day. And it just leaves us in no man's land.
Thank you for that feedback. It's important to resolve those issues locally. And it has to be local. And if those are not resolved locally with the lead medical examiner, then please get in touch with the regional medical examiners and their officers. Contact details are with Mohammed in the National Burial Council. And we'll do what we can to resolve those issues.
Hi, Nasir Mupara from London. My question was that community deaths, I understand, will also be referred to medical examiners, including palliative care and end of life. Why is that necessary?
Thank you. It's certainly the case that the legislation, when it's commenced, means that all deaths that are not investigated by a coroner must have medical examiner scrutiny to enable registration. That is the primary legislation. I understand the point entirely about palliative cases. I do. I can tell you that there are some palliative cases where concerns are raised, nevertheless, about care and issues, and getting the certificate right is also really important. So it's a way of improving, even those palliative cases. Way of ensuring that those cases pass seamlessly through this, touching on the last point, is that advance notification of palliative and expected death to all parties so that communication certification is already there preempts the right things being done as quickly as is practically possible when the death has actually occurred. So I commend to you that principle of communication early. Yes, sir.
Hi, my name's Idris. I have a question about the pilot. Will we have independent voices and engagement to review the pilot and see the outcomes?
So the pilots are local, yes, not national. This is not my. I have a slight issue with the word pilot because it implies that something is going to be tested and then stood down. What I would prefer is that something is tested and refined and improved and continues because we are heading towards the statutory system. Locally, I would expect all pilots, whether to use that word that I don't like, to have input from the community leaders because that's the reason that it's being done. So, as you asked for the independent voices, I would hope that the independent community representatives are included in the design, testing and feedback on those tests.
Two more questions.
Hi, my name is Rogaya. I'm from Barts Trust. You've actually touched on it. We're saying preemptive, but that's not happening at the moment. And where we have faith leaders or chaplains within the hospital that are fully aware that somebody is imminently passing away, the family have been called in, and it's actually part of their treatment to be able to be buried fast. It's part of the comfort that the family requires. And where we're able to say, we know the funeral director will do this, we know the graveyard will do this, and there's all this certainty. The bit where the uncertainty is, we don't know when the medical examiner will look, we don't know what they'll say, especially if a consultant is dealing with the patient and will happily say, I know the cause of death because I've been dealing with them, I know this family. Medical examiner is looking at what the MEO is passing him through a screen, through notes on a paper. So is there a way of setting up a system? So it's not ad hoc, it's not potluck, but it's actually part of the system where if somebody's running end of life, whether it's in the community through a community leader or within the hospital through chaplains and consultants that are there in palliative care, it's always preempted.
Yeah, I understand the point. I cannot prescribe that from a national perspective because each office is different and each area is different. I have big offices, I have small offices. I have split site trusts, I have single site trusts, I have large urban areas, some with very few acute hospitals altogether. And I also have difference in demographics, with ethnicity, population. There are improvements on the horizon. So to reassure you, despite me saying no, the answer is actually yes, because locally, I would commend that relationship between the chaplain and the medical examiner office is critical. To say we have this, we have a doctor already. They know what the cause is. There aren't any issues. So when it happens, let's just move this through as quickly as feasible. If everybody knows it's all about communication, it can happen. It can be all unlocked locally. If I try to say that every hospital in the country must consider every palliative case, regardless of faith or urgency, I've got a problem. And that's open to misinterpretation. The final thing to mention is that the Department of Health and Social Care are advancing an electronic medical certificate of cause of death. It's existed elsewhere, including France and lots of parts of the world, for ages. But it's getting there. I don't have responsibility for that, but if we can introduce that as well, it means that remote certification, so when somebody's not physically there to sign a book, that could speed things up too.
Just really short time, the last question.
Just a quick one. My name's Atika, I'm a GP from Buckinghamshire. You mentioned that the criteria for the attending profession might change, and I was just wondering when that might come in, and I don't know if you can share what those changes might be.
I can't. Thank you. I'd like to be able to say this, but this is this is currently being discussed between government departments and lawyers, because you have to consider the implications for this. I strongly support simplifying this, making it more straightforward for a doctor who has attended the deceased to be able to complete a medical certificate of cause of death in whatever circumstances they find themselves in.
Thank you very much. I hope you found that useful. Unfortunately, as we say, we've got to leave.